Hello everyone, good evening and welcome to the second webinar of the fourth series of ICPA clinical series. And in today's edition we have Dr. Manish Agarwal, well-known prosthodontist, renowned for his work in full mouth rehabilitation and occlusion. Dr. Manish Agarwal has had an illustrious career in prosthodontics. He has been a consultant to multiple clinics across Mumbai and outside Mumbai. He was also a professor in one of the renowned dental colleges, and he has been maintaining two successful practices, one in Thane and the other one in Bandra. Today he will be filtering out his 2 decades of experience and giving some problem solving frameworks as well as some clinical tips on one of the very complex issues that practitioners face in prosthodontics, that is how they can overcome the challenge of occlusion and utilize it to their best capacity in order to get predictable results in full mouth rehabilitation. And we also have Dr. Avinash Shar with us, who is a TMJ specialist, and he is an MDS in oral medicine radiology. But again, for the last 2 years, he has found his niche in TMJ disorders and how to solve TMJ issues on priority before you attempt full mouth rehabilitation. So we thought that Avinash would be a best fit to become the guest moderator for today's session. So now I'll hand it over to Dr. Manish Agarwal. He can start his session, and once the session is over, Avinash and I will come back and we'll start with the questions sent by the delegates. Manish, it's all yours. Thank you.
Good evening, one and all. Thank you, Rajiv, and thank you, ICPA, for giving this wonderful opportunity to express my views on occlusion in FMR. So let us start the journey to make it more predictable and more precise in our day-to-day practice. Before I start my lecture, I would like to take the blessings of Lord Ganesha. This is my free time soap carving, which I am into. Okay. So occlusion in FMR. So how often do you see such cases in your clinical practice, okay, where a central incisor is missing? Now this must be a very cakewalk case where you can replace this with the help of a simple RPD or maybe a single tooth implant or a 3-unit bridge. But the case doesn't look that simple when we go to actually see the occlusion. Okay, this is what we see in the mouth. Now any of the above 3 treatment modalities which I have explained is going to have a failure if we don't take care of your occlusion problems in this particular case. Let me share you another case wherein upper is dentulous and lower is edentulous. Okay, but actually when I see the occlusion, okay, now this is what is there. So we have a deep bite case where occlusion is a major problem. There is a posterior collapsed bite because of which anterior, lower anteriors are not seen. So this again will require a coordinated approach of full mouth rehabilitation and proper occlusal planning. Another case wherein you can see a total deep bite case. Okay, in this case, you may at first instance you see that there are no missing teeth, but when I open the bite and check his occlusion, you see the 2 lateral incisors missing. Now, replacement of this 2 lateral incisor becomes a problem if you don't take care of occlusal consideration in this particular case. Another case wherein you can see a lot of wear and tear happening. This is because of the lifestyle of this particular patient. You can see a lot of attrition. You can see a lot of erosive activity. There is no anterior guidance, complete collapsed bite, okay, and a broken down dentition. So we'll be discussing the cases, okay, and further I'll be going into details of how to manage this particular kind of cases. So today, what are we going to study? The broken down dentition, its causes, the consequences, signs and symptoms, treatment options, and different restorative techniques of how to go ahead and solve these particular cases in your day-to-day practice. So types of broken down dentition. The diseased mouth. The dentition is nearly lost. Bone levels are usually poor. Disease level and plaque scores are high, and patient is often poorly motivated. Normal treatment in such particular cases is simple periodontal treatment like scaling, polishing, and deep curettage, extraction, basic conservative therapies, and replacement with help of partial or full denture as per needed. But what you see in a worn mouth is a virtually intact dentition, severe and extensive loss of tooth structure. Generally, little disease is present. Often, bone levels are wonderful and the periodontal conditions are amazing. Surprisingly, little or no loss of facial height. So you don't see any facial height or vertical collapse in many of such cases. Patients are often very well motivated. They are concerned about their appearances and want to keep or save their teeth. So signs of worn down dentition, complete loss of occlusal form. In the previous case I showed you where there is entire occlusion is attrited, worn off. Absence of normal occlusal guidance, so there is no anterior and posterior guidance remaining. Reduced height of clinical crown. Now this is a situation with most of the parafunctional clencher or a bruxer or a worn down dentition. So reduced height is a major problem from a day-to-day clinical practice. Exposed dentine because of wear and tear leading to sensitivity. Then we have chipped teeth with sharp edges. So basically what happens is when the patient is into the wear and tear situation, the enamel wears off and then the occlusal dentine gets exposed. Because of this exposure of occlusal dentine, the dentine wear off or the erosion takes place faster compared to the walls of the enamel from the buccal and lingual side. And everybody knows that enamel needs support to stand. Now, since the dentine gets eroded faster, the enamel stands tall, and one finds that this unsupported enamel fractures. The patient comes to you with the complaint that, Doctor, my teeth are breaking or chipping all of a sudden. But this is not all of a sudden. This happens over a period of years, depending upon the severity of the disease. So chipped teeth with sharp edges are because of broken enamel from the buccal or lingual. If it's on the buccal side, it will cause you a lot of lip laceration and cheek lacerations. And if it's on the lingual side, it causes a lot of tongue laceration. Now, most of the time when this patient comes to you, you try to just make it smooth. But now from tomorrow onwards, if you get such kind of patients, then you start thinking that why this has happened. So this is because of the occlusal disease that the patient is going through, maybe because of attrition, erosion, or abstraction, or combination of all the above. Because of the chipped teeth and sharp edges, you feel scarring of soft tissues around, as I explained you, on the buccal side, on the cheeks and the lips. And on the lingual side, you have tongue. And then we see repeated worn out and broken down restorations, okay, maybe done by you or by the next door dentist. So because of the occlusal wear and tear, the fillings or the restorations or your full crowns or inlay onlays keeps breaking multiple times. So what are the signs and symptoms? So suddenly you see a sensitive tooth in the patient's mouth. That is because of occlusal interferences. Especially you will see this in the second molar region because that molar is close to the joint. Okay? So your one particular tooth suddenly starts interfering and you get sensitivity. Okay, you have to now very meticulously check for your interferences either directly in the patient's mouth or you have to do a occlusal mounting on a semi-adjustable articulator. We are going to details of that later into the session. Okay. Then you will have hypermobility of one individual tooth. So that means this is not a periodontal problem, but this is an occlusal problem. So once you remove the interferences or your interfering contacts, your hypermobility will slowly become normal, okay, without any problem. But for that, you will have to find the interfering contact and then do a selective coronoplasty, okay, if possible in that particular situation. Okay. Then we have fractured teeth or split teeth. This is generally seen in a tight bite situation when the patient have a surface to surface contact. Patient is a clencher or a bruxer, so you will find this kind of fractured cusp. Then you have muscle issues, okay, where MPDS sets in. So basically what happens is when the tooth are not able to take the load, the bone will take the load. So when the tooth is not taking the load, that means it is getting attrited or it is getting fractured. When the tooth is strong, the whole load goes to the bone and the tooth starts becoming shaky or mobile. But if the bone is also strong and the tooth is also strong, the entire force goes to the muscles and you'll get a muscle pain in that particular case. But if the muscle is also strong, then the whole point goes and shifts to the temporomandibular joint, okay, and the patients get TMD issues. So Dr. Avinash is here with us, who's an expert in this particular field. Okay, so he may throw some light later into this session of TMD. And then these are the signs of your bone mouth feature where you'll see. So this you must be finding in your day-to-day practice, where you can see a lot of attrition, abrasion, erosion. Okay. The bone mouth feature is, now you see this is typically because of erosional activity, because of the gastric reflex of the patient. The amalgam fillings are standing tall, whereas your enamel is completely eroded. The erosion is such that you feel that somebody has nicely taken a diamond point or a carbide burr and made wonderful margins for some beautiful restorations. But this is not the case. This is a diseased mouth, the bone mouth, because of erosion. Okay. Again, here the patient has a line sucking habit, so your anteriors are completely eroded and the entire load comes on your posteriors. Okay, here we have loss of your anterior guidance leading to posterior wear and tear again. So completely destroyed dentition, you can see the amount of attrition which you have. And the end result is a collapsed bite or a pseudo class 3 kind of jaw relationship, because when the vertical collapse, the mandible moves forward and upwards, leading to your class 3 kind of situation. Okay. But not a major issue. This can be easily solved by different easy methods of treatment modalities, which I'm going through my presentation today. And this is what you see in the end, the destroyed dentition or completely bad occlusal form of your particular patient. So now, once you have seen the signs and symptoms, let us briefly go towards the cause of worn down dentition. So causes are erosion, attrition, parafunction, and bruxism. Different kinds of habits like nail biting, pencil holding, thread holding, and various others. Medical problem like gastric reflex and bulimia. I'm not going into details of all this, okay, but we'll just cover a bit. So this is what erosion is all about. Okay, so erosion can be because of the acidic reflex from the, so it is called as intrinsic acid, and sometimes it is an extrinsic acid because of the beverages that you have in your day-to-day life. So that can be cola drinks, that can be lime juice, that can be some vinegar, okay, or aerated drinks. Okay, all these are extrinsic acid which cause a lot of erosive activity if have continuously or chronically the patient is consuming those. Okay, attrition is total occlusal surface wear and tear. This can happen because of bruxism or it can happen because of parafunction. Apart from this too, the patient if having a chewing habit, then you will find this kind of attritional activity. If the patient is having supari or any other betel nut kind of chewing habit continuously, okay, then you will have this kind of attritional activity. So this is your anterior attrition, typically a kind of a driver's personality where the patient have an anterior edge to edge grinding habit because of which there is a lot of wear and tear. So abrasion because of some nail biting habits. Okay. Now see this particular case where you see the enamel has thinned out because the patient has a nail biting habit, and if you carefully see on the right central incisor, you have a class 5 defect, which is because of the abrasion, abfraction. Okay, so the patient was having a habit of chewing nails or nail biting habit, and this has led to thinning of your central incisor edge. At the same time, the occlusal pressure have led to an abfraction cavity in the cervical region. Now, this patient is none other than it's me, okay, myself. Okay, I had a habit of nail biting for quite a few number of years till the time I got my central incisor chipped off. That day I realized the importance, because I know now there's no way I can build this particular central incisor. So I did a very big investment in my life. Okay, and you'll be surprised to know that investment was of a nail cutter. Okay, so and from that day onwards, my nail biting habit is almost gone because I was worried about my central incisor getting further worn down. Then we have abrasion or abfraction cavities. Abrasion can be, so you see a class 5 type of cavities in the patient's mouth. If it is unilateral, it can be because of abrasive activity of your brushing techniques. Okay, or okay, if it is bilateral, then most of the time it is related to your abfraction. Now, in simple terms, I'll explain you what is abfraction. Abfraction is where when the occlusal forces are there, okay, the tooth flexes. This flexure causes the cemento-enamel junction, okay, to break, okay, because the enamel rods are placed in an oblique direction, and this leads to class 5 kind of restorations. But you will see this generalized all over the places, right and left, and also in the labial areas, in the incisors. Okay. Then we have splayed teeth. So when you have missing posterior teeth, okay, then your anteriors are going to, the lower anteriors are going to hit the upper anteriors, because of which you get splayed teeth in the patient's mouth, and you feel lot of diastema and proclination in the maxillary arch. Okay, because there is no posteriors, so there is a collapsed bite, because of which you see this kind of symptom. So treatment options in this particular cases are, will have, most of these patients will have an experienced year of repeated fracture of teeth and restorations, will be skeptical about any treatment that you are going to offer, but will be hoping for a miracle. So when the patient comes to you, we have to approach with cautions, because these are not going to be a simple treatments. We are going to involve multiple steps in rehabilitating this particular patient for a better functionality and a super looking aesthetics. What are the treatment problems? Okay, the real underlying problems are, first is the lack of height in which to restore the individual teeth. Second is complete loss of normal occlusal protective and guidance mechanism, and ongoing erosion, attrition combined with a highly destructive parafunction habit. So severe loss of vertical dimension, so no space for restoration. You see the amount of tooth loss, which leads to vertical collapse, and now none of your restorations are going to survive on this particular teeth. Okay. You see the amount of wear and tear. You see the enamel. You can see the wear facets, the dentine exposure leading to sensitivity, and in few areas you see enamel walls getting fractured. So the treatment options are, this problem requires a coordinated full mouth approach. Any individual patchwork will lead to failure. So careful preparations and planning is essential for success. I'm going to briefly take you through a journey of how to plan this particular cases. Okay, but because of lack of time, I may be very precise and short. Okay, details can be explained maybe later in the question answer session, or we will have some future sessions in, or maybe we keep conducting some courses on this particular topic. Okay, they are all 3-day courses. Okay, completely elaborated. We can do that in future. Okay. So treatment planning, complete full examination, make accurate study models after you examine the case, mount the models on a semi adjustable articulator. We call this as a diagnostic mounting. Very important step. Study the patient's pattern of the occlusal wear, which I've already explained you about their attrition, abrasion, erosion, and the contributing causes of why this have occurred. Then we do a diagnostic wax-up, that is a trial bite raising setup before we proceed for any kind of irreversible change in the patient's mouth. So let us go with phases of treatment. Phase 1, phase 2, phase 3, phase 4, phase 5. So phase 1 is control phase, where we will be controlling the causative factors which has led to this particular problem. Phase 2 is bite raising phase. I'll be covering each in part into detail. So phase 1 is control phase, establish the cause of tooth structural loss, educate the patient to make changes in the diet, lifestyle and habit, monitor to establish stabilization, discuss long-term options with your particular patients, okay, because this will involve a lot of commitment from time and financial point of view. Phase 2 is bite raising protocol, okay, because the bite is collapsed and now the only way to restore is to raise the bite, in other terms to restore the vertical dimension. But how much is needed? How much will your patient tolerate? So for this we have a very simple tool by giving an acrylic bite raising appliance, which is reversible and non-invasive way to test whether my patient can tolerate and how much my patient needs to raise the vertical limit. So this is a very simple appliance. I'm going to show you in further slides. Surprisingly, patients are accepting and often reports an increased comfort in eating. Their symptoms are gone, the symptoms which you get because of the MPDS and some amount of TMD problem because of the collapsed vertical. Okay, so bite tracing acrylic appliance, it's made up of clear acrylic which covers all the occlusal surfaces and the incisal edge with a friction fit. So here we don't have any clasp, we don't have any occlusal surface, we have only clear acrylic which is covering the entire occlusal surface and 2 millimeters of buccal and the incisal edges. Must follow all the laws of ideal occlusion. Now, I'll just go in brief of what are the laws of occlusion. First law says all the teeth should come in contact when the patient is into centric relation. Second law says anterior guidance should be in harmony with envelope of function. Third law says that when protrusion, posterior should get disoccluded. Fourth law says on working side, if patient is on the working side, the non-working side should go out of contact. And rule number 5 is in excursive movement, the canine should disocclude all the posteriors. If the canine is attributed, then you get a group function occlusion. Okay, so 5 laws of occlusion. The bite plate should follow all the laws of occlusion. Then once you give the bite plate, okay, the time for this is depending upon the patient's symptoms. If the patient is asymptomatic and you just want to raise the vertical where the patient doesn't have TMD or muscle problem, 1 week is sufficient. But if the patient is having symptoms related to muscles and the joints, then minimum 6 weeks wear of this particular plate is very, very crucial and important. We can't enter into rehabilitative procedures till the time your muscle and joint symptoms are eliminated and stabilized for at least 6 weeks to 6 months period. Then we will review and refine and monitor the patient's response once we give the bite raising appliance, whether the vertical dimension which we have planned for the patient is able to accept it or not. Acrylic can be removed or added depending upon the patient's symptoms or patient's response. Remember, we are increasing the vertical dimension of occlusion. So this is an animated slide where you can see the bite is propped open with the help of a acrylic plate. So this is, you can say, occlusal stabilizing splint. Okay. Once the patient is comfortable with the occlusal stabilizing splint for a period of 1 week to 6 weeks, then we convert your plate height or dimension into provisional buildups, which can be either through a direct mock-up. We do a mock-up on your study model, and that can be converted into provisional restoration with the help of direct provisionals in the patient's mouth with pro-temp, or you can do a freehand composite, or you can make a lab fabricated temporaries, or you can make a polymethyl methacrylate temporaries, that is PMMA temporaries. So there are multiple ways of giving provisionals in the patient's mouth after we establish a new OVD, but there is occlusal vertical dimension with the help of occlusal stabilizing splint. Then we review and refine whether my patient is comfortable with the existing provisionals. We equilibrate our occlusions, see to it that all the laws of occlusions are fulfilled in the provisional setup. Okay. Monitor any further wear, plan the long-term restorations. This will be a major commitment to time and money. Then the long-term build-ups, once the patient is ready with the provisionals, we convert the provisionals into finals. Space is now available. What our problem was, loss of vertical dimension because of the plate and the provisionals. Now the space is available. In this space, you gradually replace your final restorations with the help of tabletop restorations if you want to be more conservative, or you can go with full crown restorations that can be PFM, zirconia, or Emax. Okay, and you can replace your anteriors with the help of better composites, or maybe crowns, or maybe veneers. Okay, that is bonded porcelain restoration. So basically, for all this, we'll require a multidisciplinary approach because there are multiple fields that are involved in doing a full mouth rehabilitation. We may require an endodontic help if certain symptomatic cases. Now, again, when I talk about endodontics, not all full mouth rehabs need endodontic treatment. Only a symptomatic tooth will need an endodontic treatment that can be clinically and radiographically evaluated. We may require certain periodontal help. So we have Rajiv with us, who's a great periodontologist, for crown lengthening procedures and other perio-related problems. Then we have surgical help from oral surgeons for extraction, frenectomy, tuberectomy, and removing of tori. And then comes the prosthodontic for your restorative and rehabilitative work. Once we do our restorations, I generally tell in prosthodontics that it is a after sale service which is clinical follow up. That after sale service should be after 1 month, 3 month, and then post that every 6 monthly for any kind of restorative or rehabilitative work that you are going to do. Okay, so we have to do detailed clinical examination before you enter into all the step. I'll be discussing a case in detail for that. So clinical evaluation, what you have to check is attrition, abrasion, loss of vertical and collapsed bite, temporomandibular joint problem, check for your sensitivity, repeating the restorations again and again, collapsed posteriors or anteriors, collapsed bite with multiple missing tooth and supraeruption, that is where the plane is gone for a toss, correction of occlusal plane, and so on. Okay, so for after your clinical evaluation, you are going to make a good diagnostic cast. Okay, that can be done through analog technique or the digital technique now. For that, you will require an orientation relationship or a phase bow transfer. So basically, I'm not going to detail of phase bow, okay, but what phase bow does is it orients the maxillary cast exactly precisely the way it is there in the patient's mouth onto your articulator. It locates the hinge axis, which we call as a terminal hinge axis. So your centric relation is maintained even if we increase or decrease the vertical dimension on your articulator by few millimeters, okay, which is a need of an hour for your full mouth rehabilitation. And it also maintains the same arc of closure. In your day-to-day practice, you must be finding most of your single crown after your post RC restoration. When you do, you get a lot of high points. Now, this is because the arc of closure of the articulator on which the crown is fabricated and the arc of closure of your patient's mouth is not matching. So, phase bow is going to match the same arc of closure, and the interferences, your clinical interferences, which you are going to find in your restorations, are going to be eliminated by at least 99%. Okay? So for that, you have to just take a bite fork. I'm not going into details of that. You have to take a phase bow transfer. Maybe again, we can take a course on orientation relationship in future. Okay, ICPA and Raji will help us out with that. So orienting the maxillary cast with the help of a phase bow. Okay, and in future we are coming up with this particular course. Okay, so the details are given on your screen. Maybe you can just take a screenshot and contact us in future for this particular course which we have planned in May. Okay. Now we go with recording of your interocclusal record. So first was orientation relationship. Now we record the centric and the vertical relationship. Okay, so determine the amount of vertical to be restored. Now I'm sure many of us are always have this dilemma of how much should we restore. Okay, what is the optimum? Am I correct or not correct? You have a self doubt in determining this. Now, here to be very frank, it is a vertical dimension is a subjective procedure. There is no one method where you can say that this is an accurate method. There are multiple ways you have to find out of how to increase the vertical. Again, I'm not going into detail, but the easiest way is to fabricate a acrylic splint, occlusal stabilizing splint at the determined vertical dimension. So you can use physiologic method, that is Niswanger's method, the way you use in your complete denture therapy. You can directly raise it on the articulator. You can check your freeway space. If the vertical is collapsed, you have too much of wear and tear of occlusion, and you have a freeway space when the patient speaks certain words like Ram, Am, Sham. Okay, that will give you a vertical position at rest. Okay, and after that you depart your lips and your teeth are separated by say 6 millimeters. Okay, the amount of freeway space ideally is 3 millimeters. That means you have 3 millimeters of space to encroach on your vertical. Okay, so again, I'm not going into detail. So when OVD must be changed, when we don't have enough space to restore, the OVD must be changed for functional and aesthetic needs of our patients. In case severe arch mar relationship or extreme occlusal plane problems, Note, we cannot increase the occlusal vertical dimension of one particular tooth. Okay? So, how much to restore depends upon the aesthetic and functional needs to be evaluated with aesthetics and phonetics. So, this is the way we can check. Okay, when I talk about aesthetics, we see your facial height proportions. When we talk about phonetics, we check about V sounds and F sounds. When the patient says F and V sound, the lower vermilion border is touching the upper central incisor. In worn down cases, that is not possible. Okay. S sounds, when you pronounce the S sound and you have a lot of freeway space, that means there is a time you can encroach the vertical dimension. Amount of freeway, as I explained you, if you have a freeway which is 6 millimeters, the ideal is 3 millimeters, so we can encroach by another 3 millimeters in the patient's mouth. And ability of the patient to tolerate. Patient can tolerate X number of millimeters of increasing the vertical dimension. But our main aim is to how much is do we need from our aesthetic and functional demand. Okay, so we have, suppose the optimum is 2 to 4 millimeters, maximum is 5 millimeters, that you can raise your vertical dimension for an individual patient. Now, centric relation. Now, this is again a taboo where people are scared of, okay, whether I'm into right centric or whether my centric went wrong. So, centric position of mandible is the relation to maxilla is defined by the position of the condyle. It has no relationship with the teeth. When the teeth comes in contact, it is a centric occlusal position, also called as MIP, that is maximum intercuspal position. Okay, so acceptable position should be conducive to health and relatively repeatable. I generally tell it as RRR position, repeatable, reproducible, and a recordable position. The patient should comfortably go without any efforts again and again into the same position, that is your centric relation position. It is independent of tooth contact, clinically discernible when the mandible is directed anteriorly and superiorly against the posterior slope of articular eminence against the articular disc. Okay, so both the slides you see two pictures. In the olden days, before 1997, we have the maxillomandibular relationship where the condyles is in the most retruded position, and but now we manipulate the mandible with the help of bimanual method or Dawson's method into an anterior superior direction. Now all this into details can be elaborated into maybe some course, or maybe we do a lot of hands-on training sessions. Okay, where we'll be sending you the details of the same. Okay, because this time is too short for me to go into details of each and every technique. Okay, but then they are all very simple. Once you mount the maxillary cast and determine your amount of vertical to be raised, you guide the patient to centric relation and mount your mandibular cast on your semi-adjustable articulator. Now we are complete with your diagnostic mountings. Okay, now we have one more record which is called as a protusive record that will give you your horizontal condylar guidance, if that is directly related to your cuspal angulation of what is going to be your anatomy of your teeth. So in simple terms, I'll just give you in two lines. If you have a steep condylar guidance, your cuspal angulation is going to be steep. So if you see in a young patient, in a 21 or 25 years old patient, the condyles are sharp, rounded and steep, and the cuspal angulations are also almost 33 degrees. So if you see the condylar guidance in a natural, normal dentate patient, it ranges from 30 to 35 degrees, and the cuspal angulation also will the anatomical tooth have a 33-degree angulation of the cusp. So condylar guidance and the cuspal angulations are directly related. In an older patient, imagine a 60-year-old patient where the condyles have become flat because of wear and tear, the occlusal surface will also be flat. Okay, there you cannot give a high cuspal angle. Your restorations will fracture over a period of time. So condylar guidance cannot be ignored. You have to take a protusive record, program your articulator, and check your condylar guidance depending upon what you get in the patient's mouth. Okay, so once we mount your diagnostic cast after your clinical examination, okay, then you do a mock-up trial where you do a diagnostic wax-up for your final results. Okay, and you develop all the laws of occlusion, the aesthetics, the phonetics, the vertical height to be restored into the centrculation which you have recorded for your patient. So this is your diagnostic cast, and then you do a diagnostic wax up, okay, after your mounting, okay, and established all your laws of occlusion into this particular diagnostic wax up as you want it into your future final restorations. So this is your posteriors, okay, where anteriors comes in contact, posteriors are going out of contact. This is we are achieving in your diagnostic wax up. Develop different types of occlusal scheme, as I already explained you about the canine guided, group function, and mutually protected occlusion. Okay, so you have to select depending upon your clinical situation what type of occlusion you want to load depending upon the individual teeth health in the patient's mouth. You develop either a canine guided or a group function occlusion. Once you fabricate a diagnostic wax up, then you take a putty index and fabricate a template to fabricate your provisionals from this particular diagnostic wax up. So there are multiple ways of making it. As I told you, you can make a putty index, you can make a template. Nowadays, you get a digital wax up done, okay, and then you can transfer that by the help of a polymethyl methacrylate, that is PMMA temporaries. So multiple ways of transferring your diagnostic wax up to your provisional restorations. Once the patient is comfortable with your bite plate and your bite which you have vertical which you have increased, okay, then you go with your prosthetic sequence wherein you prepare your posterior teeth and give posterior provisionals. Then you prepare your anterior teeth for veneers or whatever and give anterior provisionals. Then you make impressions for your restorations, complete all the necessary steps like metal coping trials, ceramic trials, shade correction, final glazing, cementations of your posterior restoration. So this is your prosthetic sequence one by one. Okay, so again I'm repeating: posterior tooth preparation first, posterior provisionals; anterior tooth preparation, anterior provisionals. Once the patient is comfortable with the provisionals, okay, then you make your impression for your final restoration. It can be done in sections or all together depending upon your clinical experience. Complete all the necessary steps of your restorations like your metal coping trials or ceramic trials, shade correction, and then you finally glaze and cement your restorations. Okay. So I'm just quickly going through one particular case, okay, where this patient is in his between 55 to 60 his age was, and this was his pre-operative smile. And you see the intraoral view. So mandible are standing tall, but the maxillary is completely collapsed bite. You see the amount of tooth structure remaining. It's hardly anything, maybe only 2 millimeters here and there. Okay. So I'll show you the lateral view of this particular case. So this is a lateral view. This is the occlusal view. You see the complete loss of wear and tooth structure. Okay. In the today's era of implant dentistry, people will think that okay, let's extract this and replace this with all on 4 and all on 6. Okay, 72 hours implantology and all the stuff. But let us save the natural teeth as far as possible. Okay, so this is your mandibular situation. You see the amount of disease that this patient is having, occlusal disease, where he's having attrition, he have erosions, and also the parafunctional habits. Okay. So treatment problems are lack of height to restore the individual's teeth. You saw hardly 2 millimeters of tooth structure left. Complete loss of normal occlusal and protective guidance mechanism was there. And ongoing erosion and attrition combined with a highly destructive parafunctional habit are present in this particular case. So my plan is to restore the lost vertical dimension, to correct the occlusal plane, to restore the function, and to restore the aesthetics. Okay. So phases of treatment is restore the lost vertical dimension with the help of occlusal stabilizing splint. Second is surgical crown lengthening phase, where I raise the flap and increase my crown height. Phase 3 is my provisional build-ups, where I am going to give provisional to my patient after from my diagnostic wax up. I will review and refine whether my patient is adjusted to my provisionals. I will check your occlusal equilibrium over there. Phase 5 is long-term build-ups with the help of either a porcelain fused to metal restoration or metal-free restorations. Phase 6 is recall and maintenance, which is after-sales service. So this is your diagnostic wax up. Okay. From now, what is the first tooth that you must have arranged in the patient's mouth? Okay, that is a central incisor. So the length of the central incisor should be approximately 10 to 11 millimeters. In this case, we have only 2 millimeters. If we build another 8 millimeters over the existing 2 millimeters, my restoration is not going to survive. So my plan over here is to go 4 millimeters above the gingiva and 4 millimeters below the broken down dentition. So 4 millimeters above, 4 millimeters below, and 2 millimeters of the original tooth structure will give me a 10 millimeters of tooth height. So this is what my plan is: 4 millimeters above, 4 millimeters below. Okay. So this is my diagnostic wax up. Okay, lab courtesy from Zenith Dental Laboratory, Sagar Limay. Okay. And you can do this digitally in this digital era now. So this is your occlusal wax up. This is the complete wax up on a semi-adjustable articulator. Then I go 4 millimeters above by raising the flap. Periodontal surgery done by my good friend Dr. Om Bagele. Is a fine periodontist. So he raised the flap and gave me such beautiful height for this particular tooth. Then for the occlusal height, I'm going to give a bite raising clear acrylic appliance by occlusal stabilizing splint. So this is the way the patient is going to wear the splint. This splint follows all the laws of occlusion. You see the healing of the tissues. This is after 1.5 to 2 months of healing. Okay, patient is getting used to this particular bite plate. We have raised it by approximately 4 to 5 millimeters now. And now we go with the prosthetic sequence, that is tooth preparations and provisional restorations. So I'm preparing my teeth, redefining my margins, okay, doing my retractions, making my impressions, and these are my provisional restorations fabricated in heat cure acrylic. Okay. Lateral view. Okay. So this is now once the patient is comfortable with the provisionals, I'm going to convert my provisionals into the final restorations. So this is my final restorations. Okay. So our porcelain fused to metal restorations. You see the gingival health. This is my bite, which we have established an occlusion after doing a lot of planning and execution through occlusal equilibrium. This is the lateral view. This is my pre-op and post-op from the frontal view. This is my pre-op and post-op from the right lateral view. This is pre-op and post-op from the left lateral view. Pre-op and post-op smile. And this is just 7 years to 8 years follow-up. This picture was taken after 8 years into service. Okay, you see the maintenance of the health of the gingiva. Restorations are still intact. So, you see, this is 7 to 8 years follow-up. Gum health is maintained. Patient have maintained it very well, and the occlusion is stable now. This is 7 to 8 years of follow-up. Left and right lateral view of your restorations. And this is post-op smile after 7 to 8 years. Happy patient, happy me. So basically, proper diagnosis, detailed treatment planning, and a meticulous execution of the treatment plan are essential for a healthy, functional, and aesthetically pleasing, predictable results. So thank you for your patient listening, and thank you ICPA and Rajiv for this wonderful opportunity again. That's my contact number, and that's my email, where if you want to contact me personally, you can do that. Okay. Also, my Insta handle is there, and I'm also active on Facebook. Okay. So in your question answer sessions, now I'm open for question answer session, and if you want to enroll yourself for detailed planning and detailed explanation of all the steps which I have told you, okay, the details I've shared you on your screens. Thank you.
Thank you, Manish. Thank you for that wonderful lecture. And the final results of that case were amazing.
Thank you.
And
Thank you.
I take this opportunity to invite Avinash Kshar DMJ specialist to join this session. What we'll do now is we'll take up the questions sent by our registered delegates. So what you can do is, if you think the answer has already been given in the lecture, you need not take it up again. Okay.
Sure.
So the first question is how to do bite raise in generalized iteration cases, and how to create space if the patient has multiple missing teeth.
Okay. So this is a very common question asked by most of the participants, and there is a confusion always of how to and how much to raise the vertical dimension. Okay. So there are multiple ways of doing that. So basically, I apply the complete denture principles when I raise the vertical dimension. So the way you do your Niswanger's method, VDR, which is vertical dimension at rest, minus VDO, which is vertical dimension at occlusion. The distance is 3 millimeters, which is the freeway space. In your worn down dentition, we have three types of classifications for your patients. Okay, wherein we have loss of vertical dimension and space available. Those are the easiest case. That's Turner's classification, where you have space available, you can encroach on the vertical dimension. Okay, basically for your restoration, you need 2 to 4 millimeters of space. Occlusal clearance, if you do 2 millimeters. So you need 2 millimeters in the maxillary arch, 2 millimeters in the mandibular arch. If your vertical is extensively collapsed, maximum is 6 millimeters which you need. So one of the best method is complete denture method. That is Niswanger's method. Another way is you can use different types of deprogrammer. Okay, one of my favorite one is either Lucia jig, or the most frequently given and stable one is your John Coy's appliance. Okay, you can use that. That will deprogram your muscles, guide your mandible into centriculation, at the same time give you an available space to restore your lost dentition. Okay. Thirdly, you can do it on the articulator. As I told you, you take an orientation jaw relationship where your hinge axis is maintained, mount your mandibular cast with the help of your centric relation, and now you can increase and decrease the vertical dimension on your semi-adjustable articulator as per your need by 2 to 3 millimeters, because by doing that you are not changing, it is completely a rotational axis, you are not changing your centric relation. So that is, you can do it in the laboratory. Clinically, you can do with the Niswanger's method. There are many other method of evaluating. You can do phonetics and aesthetic method. Okay, so multiple ways. Maybe this platform is too short for me to do that, but it is very, very simple. Okay, and can be done by anybody and everybody who's practicing it.
Okay. How to restore BD or occlusion in FMR? I think you have already answered it.
Yes.
How to create space if the patient has multiple missing teeth and some teeth are touching the gingiva of the opposite quadrant or opposite arch? I think you have showed the entire case of that.
Yes.
How to record CR you have covered. What is your favorite method of deprogramming and recording CR when anterior teeth are missing?
So when anterior teeth are missing, okay, the best way again, if you have posterior teeth, this best way again is to make a John Coy's kind of appliance, okay, or an RPD kind of appliance where you suppose with my anterior central incisor and lateral incisor are missing. Deprogramming is done with the help where your anteriors comes in contact, posteriors are going out of contact, and the condyle is redirected in the anterior superior direction. Okay, that is basically in the centric relation or a home position. So for that, you make an RPD or a John Coy's appliance and your mandibular teeth. Okay, if your mandibular teeth are also missing, then again you have to make one more RPD kind of plate, and you should have only 1 point contact in both the plates, where with a small slope or a ramp, which will guide your mandible, okay, or deprogram your muscles, okay, and get achieve your centrifugation.
Okay. There is one question from a live audience.
Yeah.
Which book do you recommend for FMR?
Peter Dawson. Okay. Peter Dawson is the book. Anybody who needs that, I'll share you the soft copy. Okay, and maybe you can DM me on my number, or maybe I'll share it with Dr. Rajiv. He can share it.
Next question: how to remove protemp temporary after teeth preparation because it usually fractures?
Yeah. So whosoever have asked this particular question, I love this particular question because clinically, when you give pro-temp temporaries after your tooth preparation and you try to remove that, okay, the best method to remove is basically with the help of sickle-shaped hand scaler, okay. But in most of the cases, okay, because pro-temp work on a shrinkage principle, it's very difficult to retrieve that. Secondly, they are thin and a weaker material, so they break. That's why in my presentation I showed you temporaries fabricated with an heat cure material. Okay, they last you longer. Okay, easier to remove them at multiple step, and you don't need to make provisionals multiple time at every trial which you do in the patient's mouth. I would like to add one more thing over here is from my clinical experience. Nowadays, the in thing is PMMA temporaries, which are milled temporaries. Okay, they look very good. One disadvantage is they are slightly on an expensive side. Another disadvantage, they are highly polished. So bonding them with a temporary cement becomes a nightmare. They keep dislodging in the patient's mouth, which loses a lot of patient's confidence when you do such and such big cases of rehabilitation in those particular cases. So my choice is always an heat cure fabricated temporary restorations.
Okay. So for all those who are asking for the book, we have put the Peter Dawson book link in the chat. You can go through that.
Yeah.
Then next question is, if parafunctional habits are the cause
Hmm.
and parafunctional habits keep reoccurring, then how to
Hmm.
handle it?
Yeah. So
Avinash, you can
again,
also chip in wherever you think it is relevant. Yes,
Yes.
Manish, please go ahead.
yeah. So again, a wonderful question. So this is the question generally asked by a patient who's going through a parafunctional or bruxism, that how long my restorations are going to last if I'm going undergoing this rehabilitation procedure. My answer is very clear, depending upon the severity of the parafunction and the bruxism, mild, moderate, and severe. If the patient is a mild chewer or a mild bruxer, my restorations length will increase by number of years. So 12 to 15 years is a survival rate. But if my patient is a very heavy biter or a bruxer, or some people are into bodybuilding and heavy weight lifting, in those particular cases, the amount of forces are very high. There, my restorations are, because the risk factors are high, so my restorations are going to have some amount of failures. And in maybe 5 to 6 years' time, you may have to intervene again, okay, or maybe sometimes redo the entire rehabilitation procedure if the risk factor, which is the bite or a parafunctional, is heavy. Because we are, by treating the rehabilitation procedure, we are not going to eliminate the parafunction. We have to break those habits by control phases like meditation and lifestyle changes and certain occlusal equilibrium and all those.
Okay. Next question is, in case selection, what case should be avoided in FMR? Like, what are the contraindications?
So basically, contraindications are only very heavy bruxers or a chronic TMD and muscle problem. So if you're not able to correct that, okay, the TMD problems, okay, because by doing a rehabilitation procedure, no way you're going to be able to correct the TMD issues, okay, or the muscle issues. It's vice versa. First, you have to stabilize them and then go ahead with. Avinash will second me on that. That first TMD and then full mouth rehabilitation.
Yes. Yes, Manish.
Okay. Continuing from where you stopped last, there is a question. Won't the long span heat cure temporary fracture?
Yeah. So again, when we are planning for long span temporaries, okay, depending again upon the forces and for how long are you planning to give it. Generally, when we start your rehabilitation procedure, my first step is my bite plate, which is a reversible method of restoring the vertical dimension. That itself will be giving me all the stability. Then I'm
इधर
going
मत
from
आ
a prosthetic phase, giving my temporaries. This temporaries will be there only for
वो
a
इधर
week's
होगा
time or maybe maximum 3 weeks time. Okay, unless and until you are planning to give for a longer period of time, yes, then you will occur kind of fracture for long span cases. But I will not advise doing fixed prosthodontics for too long span cases. Maybe then those can be replaced with implants or maybe a cast partial removal prosthesis.
how to record VDR and video. I think you have covered this. If you want to add
So
a few
this was the first
points.
question. Okay, yeah, this is a very common thing which keep occurring, but again, clinically it's actually very very simple. Theoretically, maybe some people are finding it difficult to understand that, but Niswanger's method and on the articulator and the bite plate references are superb way of increasing the vertical dimension.
Okay. Question from a fellow GDCite: how to protect the new restorations?
Yeah, so whenever you have parafunctional habits, so what I tell my patient is, God gave and you broke. When I give, you are going to break. So we need a protection. Okay, now there are two concepts over here. Some people believe in hard splint, okay, and some people believe in soft splint. Okay, so depending upon the patient's comfort, in with soft splint, they say that it will enhance or elaborate your bruxism or clenching habit. But with the hard splint, the thickness is there, so patient can't tolerate that amount of vertical dimension, and certain times patient get some headaches and muscle problems. So my personal choice is always 2 millimeters of soft splint, okay, which repeatedly I have to monitor, and after every 6 months you have to do the recall and make sure my patient is wearing those for the long-term survivability of your restoration.
Okay. In FMR, which Facebook is used? Arbitrary or kinematic? And why?
So basically, in all the cases, whether FMR or smile designing or full mouth implants, currently we are using only an arbitrary phase. Okay? Kinematic phase go is very very cumbersome. Personally, I've never used it, but they say that it's so cumbersome that the outcome which you get, the benefit of using a kinematic phase go are very minuscule. So we stick to our arbitrary phase go, which are easily available at a very economical.
Okay. Choice of post and core, fiber or cast post. Do you use in your case, in your last case?
So basically, I'm not a big fan of post because post generally weakens the tooth. I'm instead a big fan of Rajiv's specialty, which is crown lengthening procedures. That gives me a good ferrule, and in my case, I've not used any post. But in case I want to use post, my first choice is always a cast post and core.
Okay. There is one more question. I think this is more beyond science. Somebody is asking how to convince patients because usually FMR costs are very high. And from your experience, what advice do you give for people who are beginners? How to convince
So
patients
again,
for
I
FMR?
tell this very simple that you have to see every case has a full mouth rehabilitation case. I'm not saying that okay from tomorrow onwards start doing full mouth rehabilitation case, but your eyes should see that yes, my patient is having some amount of occlusal disease. First, you should get convinced that okay, by doing my rehabilitation procedure, I'm going to solve the patient's functional and aesthetic demand. Okay, then it becomes very very easy to convince your patient if you tell him the functional and the aesthetic benefits. Okay, and you are having that kind of confidence to deliver that kind of results, which is self-maintaining and for a longer time, long period.
Okay. So his questions have been answered, Chandan Singh. And I'll take one more question. Okay. Based on your previous answer, but if the temporary restorations have to go for longer term, say 6 months, then whether to
Yeah.
give PMA or hit cure, what is your material of choice?
Which material due to heat cure or?
You can see the question on the screen.
Okay, I'll exit. Okay. Uh,
If the temporary restorations have to go for
Whether
longer
we
term,
give PMMA or hit cure. My
yeah,
choice is hit cure temporaries, not PMMA.
okay. So temporary means PMMA only,
No,
means
hit cure.
hit cure only. Is always hit cure.
It's hit cure.
Yeah. Can we finish one arch first and then the other one? Does the sequence matter?
Uh, so what happens is you can in the provisional stage you can do that. Okay, one arch at a time. But when you are restoring the final restorations, it has to be both the arch at the same time because then you can develop a good occlusal scheme.
Okay. Then Any role of muscle relaxant tablets, and on which phase of treatment should they be prescribed if necessary?
So basically, muscle relaxants will be needed in cases where the patient is having MPDS issues. Okay, if the patient is having MPDS issues, then that has to be solved with the help of certain splints and certain amount of deprogrammers. Once the patient is completely stabilized from that particular angle, okay, during the phase of full mouth rehabilitation, I don't think so. You will be needing any kind of muscle.
If I ask the same question to Avinash, who has been treating a variety of TMJ cases, Avinash, which are the cases where you prescribe muscle relaxants, and what has been your experience?
So muscle relaxant when the patient is having painful musculature. So what happened when you increase the bite? So muscles initially take some time to get adjust to that. So in that cases, patient has unbearable pain or muscle. You can once you palpate the muscle and you see some tenderness of the muscle. That time we can prescribe the muscle relaxant like Flexon MR. Routinely used is ibugesic and chlorsoxazole combination. It is routinely used, and along with that we can use moist heat fomentation. So moist heat. So take a warm water or hot water in that. You can just place a towel and just uh, we can apply to the affected area. So that will also help to relieve the pain.
Okay. So, on an average, what is the duration for which you prescribe muscle relaxants and the patients find comfort?
Maybe 4 to 5 days are enough.
Less
It
than a
should be
week.
prescribed twice
Maximum
daily
month. Okay.
after antacid.
Okay. Okay. Fine. Coming back to Manish, what are the key checkpoints during FMR where re-evaluation is crucial before proceeding?
Yeah, so basically the key points are your established VDR, that has to be correct. Okay, first step is in your occlusal stabilizing splint, which is a reversible way. There you will get the first check. Second check will be in your provisional restorations, where we will be again reevaluating your occlusal scheme in your provisional restoration, where you will check your vertical, your centric, and all the laws of occlusion, which I have elaborated that time. Okay, and the third check is when you are going to restore or finally cement your restoration in the final stage. Okay, at that time again you are going to make sure that there are no occlusal interferences and all the laws of occlusions are in place with the established vertical dimension and into the CR which you have established.
Okay. Before we take the next question from live audience, Avinash, how has been your experience with occlusal sprints? What are the variety of cases where you have been getting amazing results? I think Avinash, can you hear us? Fine. Let us go to the next question. In this digital world, how do we adapt? Is digital and analog combination better? Can we get rid of analog method completely?
So presently, I will advise that digital world is going to help you. Okay, and digital and analog is a very good method as of now. Okay, in future maybe when the technology improves we can completely eliminate the analog part and completely shift to digital. Few of my colleagues are already into that, but yes, there are small technical hinges here and there which will be refined over a period of years, but
Okay.
presently stick to digital and analog combination.
Okay. So along the same lines, do you recommend digital impression technique over conventional?
So my experience with digital impression is for supragingival dentistry, okay, where you're doing inlay, onlay, tabletop, veneers, okay, all those or equigingival or supragingival margins for your full crowns. There, digital works amazing. But if you have subgingival restorations, okay, or subgingival margins, okay, in certain areas that those are gray areas which still have to be refined by technology to reach that deep and take your digital impression, accurate digital impression. So I still prefer an analog method in those particular cases compared to the other cases which I have explained.
Okay. when patient got tired of treatment done, that is FMR, can we switch to GA to reverse the effect of not getting what this question is about?
Yeah.
Manish, can you?
No, I'm trying to read, but it is when the patient got tired of treatment done.
We'll come back to this question, Dr. Parveen.
Yeah,
if
maybe you can.
Till then you can retype the question. In cases where implants are part of the plan, how do you sequence implant placement with prosthodontic phases?
Yeah. So whenever implant are the part of your full mouth rehabilitation procedure, okay, segmental or maybe full, then I will first recommend a surgical protocol where you place an implant, okay, depending upon your diagnostic wax up, because prosthetic planning is will go before your surgical planning. Okay, once you establish your height, during that particular phase, the healing of your implant or authentication of your implant takes place, and then once you're done with your natural dentition, you can incorporate your implant restorations post that.
Okay. Did we take up this question before? How to record CR after full tooth preparations done? I mean, final impression after temporization.
After temporary phase, how to record CR after. So basically, I've made my full mouth rehabilitation very, very simple. Where what you do is you have an occlusal stabilizing splint, okay, which is recorded into the CR. So I'm getting vertical dimension of maybe whatever desired vertical I want, maybe 3 to 5 millimeters at an established centric relation. So how many, whenever I prepare my tooth, my occlusal stabilizing splint is going to be stable in the mouth. You have to just take your occlusal recording material like your alu wax or maybe bite registration paste, inject over there as a patient to bite, and the patient is going to be stable.
Okay.
Okay. I know this question is coming from where you use a sectional deprogrammer. In those cases, stabilizing those deprogrammer to record at the centric at the time of after doing a full tooth preparation becomes a task. So this particular splint method of doing FMR makes your life very, very simple and easy.
Okay. There is one question for Avinash. Please tell about TMJ pain associated with teeth pain. How we define about pain is from teeth or from TMJ?
Audible? Okay.
Now you are audible. Yes, please go ahead.
Okay. So first thing we need to find out the cause of the tooth pain. So it is from the tooth. There are two things: either it is a primary tooth pain, or it is a referred pain to the tooth, or it may be a orificial pain, or you can say from the muscles pain. Okay. So first, patient is having any caries, hypersensitivity, or any periodontal cause, or any high point in the tooth. Okay. So that is the first cause. Second is the referred. So sometimes the pain from the muscle are referred to the tooth, or from the, you can say, migraine pain also referred to the tooth. And third is from the orificial pain, like a TMJ pain, it referred to the tooth. So first, if there is no primary cause, the most probably that it is a referred pain. So suppose in the upper anteriors, the referred pain is from maybe the temporalis. So if you press the temporalis, the pain in the upper anteriors increases. So sometimes the patient get pain in this area, okay, and they feel it is from the third molars. But just if you palpate the middle pterygoid, the pain in that area increase. So in that way, just by examination of the oral cavity, examination of the muscle of mastication and TMJ, it will help you to differentiate the pain is primary pain, is a referred pain from the other parts of the oral structures.
Great. This question is for both of you. Which type of full mouth case do you still find mentally stimulating and challenging after years of experience?
Now you're taking the question first.
Which type of full mouth case do you still find mentally stimulating or challenging even after years of experience? Stimulating and challenging both.
So if I put it in a very funny way, then I'll say an attempted full mouth rehabilitation by someone becomes more mentally stimulating and
Yes.
challenging to do.
Yes,
So
yes, yes, Manish.
somebody has tried doing it, couldn't finish, it has come to you, then you
Yes,
take it as
a
stimulating and
challenge.
challenging. Great.
Very true.
Okay, so this is another question, Dr. Parveen Gupta. When a person has got trauma from undergoing ortho treatment and TMJ is affected and he is taking skeletal muscle relaxants, I think I am able to frame your question properly, Dr. Parveen. And with that only you had asked before. Uh, then the patient gets tired of the treatment. Then can he switch to GA to reverse the effect of skeletal muscle relaxants? What we use? There are three different questions. Okay, and there is one more question on the same line. Same person, Dr. Parveen. After trauma of TMJ, which appliance should we give? Either chiropractor or some exercise?
Chiropractor or some exercise. Maybe Dr. Avinash can answer this
Yeah,
better.
yeah, yeah. Yeah.
So I think Dr. Parveen Gupta wants to know after trauma, if the trauma has happened to the TMJ, so which appliance will help you, or a patient should be referred to a chiropractor, or some other exercises should be advised. Okay, so basically the trauma is recently happened or is happened in the past. Okay, so if it is happened in the past may cause TMJ problem, and if it's recently happened, so in that we should not give any appliance, because this is a trauma. Let it heal, and a muscle relaxant and something will help the patient, or sometimes anterior deprogrammer you can give. But trauma to what is more important? Is a trauma to the TMJ, it is intracapsular problem it is creating, or just the muscle issue? So for the muscle, you can give a muscle relaxant and moist state fomentation. So for that, no appliance will require. If it is intracapsular, then depending on the disc position or it's a fracture, you need to look for the treatment.
Okay. So some clarification by one of the audiences to one of the questions asked by another person. Start with posterior and then come to anterior. Next question, my patient had a tooth extracted, but she found a change in her bite. Does this happen when we remove a third upper molar to it? If so, how do we deal with the pain after the extraction?
Yeah, so this is specifically to the third molar. So many a times when third molar erupts, okay, that causes an interference which will deviate your jaw or displace your jaw, mandibular jaw anteriorly or maybe sideways depending upon the type of interference it is. Okay, leading to a habitual bite where the patient has gone into out of the condyles have gone out of centric basically, not a actual centric occlusion bite. The day you extract that, the interference is gone. Okay, and now the condyles are free to go back to into its normal position. That's the time you find this kind of pain, but this pain will be over if you remove your interferences, okay, which are now you can say uh, falsely developed because of the displacement of your mandible in different direction. Okay, then this particular pain will be can be easily taken care.
Okay. Next question. How to decide? This is by a registered delegate. How to decide as to how much we should raise the bite in FMR cases?
Yeah. So again, this is the same question on vertical dimension of how to decide how much to raise. So it depends upon how much vertical collapse the patient is going to have. One. Secondly, how much we need to restore the functional and aesthetic demand of that particular patient. And my same thing is depending upon the facial height, aesthetic, phonetic, Niswanger's method, BDR, video, three-way space. On the articulator, there are multiple ways of doing it. But your facial height collapse, okay, like suppose I give you an example, if my patient is having this kind of bite, okay, my lower height is reduced. Now I need to see how much my patient is increased. When I say Ram, Am, Sham, Ram, this is my vertical which I want, okay, versus my vertical which is existingly collapsed. Okay, so the difference between a collapsed bite and a Ram bite is my vertical which I'll be deciding to increase. Okay, so every case is not a formula for all the cases. Every case to case it changes.
Okay. One more case, one more question from a registered delegate. How long we need to give splint in FMR case? I request both of you to answer this.
Yeah. So
Yeah, Manish.
if you have a symptomatic patient, okay, so we categorize FMR patients into two types of patients. One is symptomatic and one is asymptomatic. If the patient is asymptomatic, then 1 week period is also sufficient. But the patient is symptomatic from the muscle part or the TMD part, then it varies upon how much amount of symptom and for how long the symptoms are there. Okay? So minimum 6 weeks to 6 months also can be the period of the splint usage. Okay, I think so. Avinash can throw more lights on the symptomatic kind of patients. Okay, where the patient is having TMD.
Yes, Dr. Manish, you are right. So suppose it is only the muscle involvement. So the temporomandibular joint disorders like myofascial pain, in that only muscles are involved, and the second part is intracapsular where the disc is involved. So you get a clicking sound in the joint, then disc displacement with with reduction and without reduction. In without reduction, you may have a limited mouth opening also, and after that, patient may have osteoarthritis. So depending on the level of your TMD, so in myofascial pain, 4 to 6 weeks or 4 months time is okay time. Then in intracapsular, maybe 6 months to 1 year with reduction. Without reduction, maybe 1 plus year, 1.5 years or more than that. And in sometimes 2 years also, we need to give a splint to the patient. So it splints what whenever we give. Before that, we check all the patient symptoms like muscle pain, then mouth opening, clicking is present or not, clicking is absent or not, whatever the problems are there be recorded, and we need to wait till most of the symptom, not all, most of the symptom get relieved. So maybe 60 to 70% the symptoms are relieved. Then we need to wait for a stabilization phase of 4 months also, so symptoms are not coming back, and then we can jump for the definitive phase like FMR or ortho depending on the patient requirements.
Okay. Next question. Regarding TMJ, we saw many OPGs with flattened fossa or condyles with intact cuspal slopes in young adults. Do we need to think about occlusal correction?
No, so directly don't jump for the occlusal corrections. So if we saw OPGs with a flattened fossa or condyles, that means the patient is having osteoarthritis. So maybe disc is displaced, and that's why the bone upper TMJ part and lower TMJ part, they are coming into contact. There's a friction between the two bones, so it is suggestive of osteoarthritis. First, we need to think why it is happening. First, try to prevent what is happening, and once you get the good stabilization over that, then you think for the corrections. First, in a more conservative way, if it is a young patient, then mostly go for orthodontics and sometimes a combination also.
Okay. I'll try to make this question easier. I think there is a patient who has only clicking. There is no pain. Can we give anterior deprogrammer when we go for the treatment?
Okay.
Like
So
some other appliance. And clicking can be taken care of with appliance or not.
So Dr. Rajesh is very good question. So clicking in the joint suggests you that patient is having disc displacement with reduction. So if you give anterior deprogrammer, then the pain in this patient in the joint, pain in the joint may increase because the anterior deprogrammer will not completely give decompression of the TMJ. It only gives 30-35% decompression anti-deprogrammer. So pain in the joint may increase. So in a clicking patient, we should give a stabilization splint or full coverage splint with anterior and canine guidance. And definitely, depending on the age of the patient and the level of the TMD, the clicking may go or may not go. So if the patient age is below 20 years, clicking easily will go. So above that, there are less chances, but most of the cases clicking go. But don't promise the patient because we don't know what internally has happened in the TMD.
Okay. So this is again a very common situation. When we prepare the last molar, you see there is a gap, but when the final crown comes, there is no gap. How to prevent this issue? Very, very commonly asked question.
Yeah. So when you prepare your last molar, okay, so sometimes you see the sinking of a joint happens. The best way to do over here is give immediate provisionalization. Okay. If you don't give immediate provisionalization till the time your prosthesis comes, you will find all the more almost negligible space as if you are never prepared to. Okay. So provisionalization is a must. Okay. Parallelism in this particular area is a must. Okay? And I personally, in most of my, maybe 60% of my cases, in the last upper second molar, I try to give my permanent restoration with a temporary luting cement. Okay?
Okay.
Permanent restoration, PFM or zirconia with a temporary luting cement for 4 to 5 weeks. Okay. Once the patient says, okay, I don't have any now high point, no gaps, no contact points are opening. Okay, everything is comfortable. I remove that and then fix it with the permanent.
Okay. There is one very interesting question. Are there any textbook protocols in FMR that you believe don't hold up in real world practice? Very dangerous question.
Yeah. Very dangerous and
You have to think twice. Okay, you can DM it to Manisha and Avinash, they will answer in private.
yes.
Okay. In borderline cases of FMR, which one do you like to do? What would you like to do? CLP or bite raise?
So when the case is borderline, then definitely it will be work with bite tracing. But when the case is severe, where too much of tooth structure is lost, then only you are going to need crown lengthening procedure in most of the cases. Otherwise,
Again,
CLP will be need only for aesthetic reason in the mild cases.
yeah, aesthetic is also important.
Okay, and one of the registered delegates has sent 4 questions together. Okay, I'll read one by one.
Yeah.
Sometimes physical open tray impression proves better than scan body impression. What could be the reason? Shifting one scan body one by one implant is good way, or engaging all at once is better. Second question, PMMA trial adjustments. How to achieve good coordination with lab so that they are on the same page? I think we can avoid the first question, scan body and other things. Let us go to this PMMA trial adjustments. How to achieve good coordination with the lab so that that lab and we are on the same page. Let us start with this question.
Yeah. So the best way for PMMA trial adjustment of how do we are on same page is beautiful bite registration protocol. Record it properly, transfer it properly. Either you do analog way or the digital way. Okay. And at the same time, your diagnostic wax-up has to be approved before the PMMA has been gone for milling process. Then you both will be on the same page, the technician and the lab.
Okay. Which temporary cement do you recommend for 5 to 6 weeks?
Friginol. Okay. Friginol is by GC, or you can say Tembond by Kerr. Okay. These are my favorite cements. They work fantastically. It will work for maybe 2 months also.
Okay. And now there are other questions like the type of occlusion and tips for beginners. I think you have covered this. Guided occlusion and relationship between prosthetic material and occlusion. If you want to add a few tips.
So basically, prosthetic material. So basically, occlusion comes first. Prosthetic material choice comes later. That depends upon your personal preferences and the patient's pocket preferences. Okay. So, but occlusion comes first. So where in Whether you use Emax, you use zirconia layered by Emax, you use porcelain fused to metal, or in some cases full metal. Okay, all the laws of occlusion followed by proper occlusal equilibrium on the day of trial, on the day of cementation, on the 24 hours, 48 hours follow up, and 1 month follow up. This has to be taken care of. There is
Okay.
no scapegoat or no shortcut for this.
Okay. Before crown, there is no food lodgement in upper 6 and 7, but after giving crown, there is food lodgement. What is wrong and how to prevent this?
So the question here, I feel it is not right one. There is no space between 6 and 7. Okay, before the crown was given. So why was the crown given? Okay, there may be some problem in that particular area that the crown was given, right? Okay, so now I'll explain you in very short way. In upper 6 and 7, okay, the maxillary bone is less dense. The trabecular pattern is less dense. Okay, so in the minute there is a bone loss, minor bone loss, physiologic bone loss, or there is a food impaction because of distal migration of your last molar, maybe it is number 8 or number 7, then there is going to be a food impaction leading to wedging effect and further migration. Plus, second molar and first molar are in a zone where they are very close to the temporomandibular joint. So there are high chances of occlusal interference. Whenever there are occlusal interferences, they act like a lateral forces. When they act like a lateral forces, the centralization of force goes and the tooth starts tipping. And that's the reason you will find a lot of space. When there is space, there is food lodgement. When there is food lodgement, that leads to decay. The decay leads to root canal leads to crown. Okay, and if you do a crown preparation on not giving a provisionals, not taking care of your lateral interferences, and not giving proper contact on the day of cementation, you are going to have all these open contact issues. These are a gray area again. So you have to be very, very meticulous in the upper 6 and 7, as I earlier also told.
Great. So this is the last question. Registered delegate has sent 3 questions together. How to provide long-term prognosis of full mouth restoration in patients having parafunctional occlusal forces? I think you have already covered this.
Yes, the splints.
Any specific adjustments of masticatory plane in case of angle class 3 malocclusion? Did you show a case of the same angle class 3 malocclusion?
Yeah, so angles class 3 malocclusion means molar to molar relationship they are talking about. Okay, basically angle when we do rehabilitation procedure, we are not concentrating on the molar to molar angles classification of. So that is an orthodontic one way of classifying it. But if I'm getting a pseudo class 3, where because of the wear and tear, because of the loss in vertical, my mandible is moving ahead, that can be easily rectified and get into a class 1 type of relationship. The minute I open my jaw is going to go backwards, okay, and downwards, leading to give me a class 1 restoration jaw relationship again. Okay, this is my bite. When I open it, it is automatically going into a class 1 type of bite, depending upon how severe my class 3 is.
Okay. So this is the last question. Definitely the last question. I wanted to ask Dr. Avinash, is there any posterior deprogrammer, YAPD or TMJ orthotics is also the same thing?
So posterior deprogrammer, so posterior bite plates or bite splints are given, but they doesn't acts as a deprogrammer, because when you give a deprogrammer, there should be a posterior separation should happen. If the posterior separation happens, then only the deprogramming of the muscle will happen. But some people give the posterior bite plates, okay, and TMJ orthotics. So TMJ orthotics are different one. Anterior positioning device. So anterior positioning device is where it is given in case of the disc displacement with reduction, and it is given only for the limited period of time. It is a non-permissive type of the splint. And TMJ orthotics is mostly given by the neuromuscular dentist after tensing the muscles. The basically it is a stabilization type of splint with the anatomy, with the tooth anatomy, the orthotics.
Okay.
So basically the anterior deprogrammer doesn't fall in that category.
Okay. If the CLP zenith becomes the problem in case of aesthetics, then
Rajiv will be better to answer this.
Perioesthetics.
so what problem are you anticipating here? So if you have done only gingivectomy, then you'll have to check what is the remaining sulcus depth. In gingivectomy, you always try to retain 1 millimeter sulcus behind. But if you did crown lengthening procedure and biologic width got violated, then you'll have to check how far the bone is from the newly created gingival margin. So in either of them, it is the space from the new gingival margin to the base of the sulcus or new gingival margin to the bone. These are the two things we take care of. So the most important point here is the two central incisors must have zenith symmetry. So that is one we look at for aesthetics, and for long-term aesthetic stability, we want to make sure that the bone levels are 3 to 4 millimeter below the gingival margin. So these are the two ways by which. So zenith becoming a problem is either because you are not maintained the biologic width, or you are not made the symmetry between the two central incisors. These are the two problems we can think of. Fine. I wanted to ask you. Okay, I think we have answered all the
Done,
questions.
done. Yes.
Okay, so that was a fantastic session. Manish and Avinash both are pros in FMR and with long decades of experience handling variety of cases. I know Manish Agarwal doing FMR consultation in hundreds of clinics for so many years. So he knows the ground realities. He knows the exact problems private practitioners face, and he has been very, very innovative in his own ways to solve those problems. Even in low resource areas, he has worked and he has given mind blowing results, very, very stable results for decades. We all three have done PG together and we have all assisted each other's cases, and it's always a pleasure to work with people
We have
like
worked in
Mani.
collaboration.
And I really like the idea that both of you are coming up with this FMR course where Manish will talk about the prosthetic part and Avinash will chip in with his TMJD part. And the people who have listened to both of them today, if you have any more questions, I recommend you can go and attend their course. And what we are going to do is in the next 2 days, we will be sending the summary of today's lecture, 5-point summary, and along with it, we'll be sending the link to the recorded lecture. You are most welcome to welcome to come back and watch the recorded session. And if any other doubts, we recommend you get in touch with Dr. Manisha and Dr. Avinash. So thank you so much. Thank you for joining in. It was a great session. Thank you once again, Manish and Avinash.
Thank you.
Wish
Thank you,
you
Raju. Thank you, Manish.
all the best and good night.
Thank you. Good night.
Thank you. Thank you, everyone. Good night.